We're very honored to have Dr. Jeffry Jacobs. He graduated from the University of New Mexico School of Medicine before the existence of smartphones. He attended Duke University Medical Center for his internship, during which time he survived several extreme weather events, hurricanes and ice storms and the like. Following his successful escape, he landed at the University of Kentucky, where he completed his residency in general psychiatry and fellowship in child and adolescent psychiatry. His professional career has focused on caring for underserved populations. For the past decade, much of his work has focused on advancing the quantity and quality of telemedicine as a vehicle to deliver specialty care in psychiatry and subspecialty care in pediatric psychiatry to rural areas. He joined the team of the University of Tennessee Center of Excellence for Children in State Custody in 2018, and I'm very pleased to turn this over to him.
All right, thank you, Dr. Berkeley. And that did sound like the bio for Dr. Jeff Jacobs, unless Dr. Gray Jacobs led a very, very similar career path.
Not nearly as exciting, I'm sure.
A cooler first name, gotta give him that. So as he said, I'm Dr. Jeff Jacobs. If you're looking me up, the first name is Jeffry, just with the one E. And so today's talk is fairly self-evident. Hopefully you all can see our introduction slide, medication management of bipolar disorder in children and youth. I made an executive decision in this presentation to not go over what is bipolar disorder, what are the criterias, what are the criterion, what criteria, what are the types, etc., because that would take all the time and we wouldn't get to the actual topic. So I'm presuming some level of familiarity with the disorder itself. If chat questions come up that I could answer quickly to clarify, I'm happy to do that. So let's see here. I'm on the wrong one. Okay, so hopefully you're looking at something that says today's topics, and just some of the things I'm hoping to cover today are the diagnostic challenges for bipolar disorder. Right after you told you I'm not going to go over them, well, I guess I am going to go over what they're not. A diagnosis called disruptive mood dysregulation disorder, and you'll understand why that relates so intimately, hopefully, by the end of this lecture. The title of this lecture, treatment of bipolar, and how do we find an effective medication. I have broken treatment up into categories of medications used, and we're going to discuss some of the more common pros and cons of the different medication classes and some specific medications to help explain some of the decision-making criteria that may go in the thinking process of a physician that is considering pharmacotherapy. Okay, so I'm going to start with a not theoretical scenario. This is a presentation that is similar to some of the most common presentations that we get in child and adolescent psychiatry. We're presented with a child that is struggling. Their core symptom seems to be irritability and anger, an unexplainable rage at very little provocation. Sometimes the child doesn't even know why they're angry. They'll say, I am so angry and I don't even know why. Yet they don't have major depressive disorder. So in children, irritability can replace sadness as the primary abnormal mood state. However, they don't meet the other criteria. They have quite a lot of symptoms of bipolar disorder. In fact, they would meet criteria for bipolar disorder, pediatric bipolar disorder, and they are every bit as severely impaired as someone with pediatric bipolar disorder. But, and this is the last line here, a non-episodic impairment. And bipolar is, by definition, an episodic disorder, where there are periods of mania or hypomania and periods of major depression, and hopefully periods of relative euthymia in between. So we've got this person, looks like someone in a mixed phase of bipolar disorder or a hyper phase of bipolar disorder, only they live there. It's not the episodic nature of symptoms that we would really need to see for it to be bipolar disorder. So what happened was, let's say, well, before the DSM-5 came out, if any of you are familiar with that, that's the current diagnostic Bible for mental health in the United States. Before the DSM-5, there was not a diagnosis called disruptive mood dysregulation disorder. It did not exist. So back in the day, before the smartphone day, these kids would come in. They clearly had a mood disorder. It was clearly wrecking their lives. Only it wasn't major depressive disorder and it wasn't bipolar disorder. So what was it? Well, people started diagnosing it as bipolar disorder, not otherwise specified, because there just wasn't a place to fit it in the diagnostic criteria at the time when we were in the DSM-4 and DSM-4 revised phases. We didn't have a place to put it. That led then to concern. Backlash might be too strong of a word, but definitely a concern that bipolar disorder was being overdiagnosed in pediatric psychiatry, and it in fact was being overdiagnosed because there wasn't another place, there wasn't another category or place we could label these people. And you might say labels aren't important. Well, they are to an insurance company if you're trying to get a medication paid for, and if you're trying to get them into psychotherapy, and if you're trying to get all sorts of resources. And they are to the school system if you're trying to get an IEP. So we do unfortunately have a situation where we do need to show a major diagnosis to help these people get services. So it was overdiagnosed. I should say it was misdiagnosed because it was both overdiagnosed and underdiagnosed, just like many diseases or disorders. ADHD has that same problem. So in DSM-5, to solve that, this category was added called DMDD, Disruptive Mood Dysregulation Disorder. What a mouthful. You just really think with all the time they had, they could have come up with something that flowed a little better. But that is what it is. I like the fact that it's very descriptive of what it is, so that is a plus for it. Compared to classic bipolar, so let's say now I'm in the current day and I'm seeing a child, and does this child have disruptive mood dysregulation disorder, or does this child have bipolar disorder? So in comparing the two, as I mentioned, the lack of the episodic nature of the symptoms is the biggest single difference. So the child with DMDD is going to have rough days most days of the week, every week. There's not going to be periods of remission. They may have depression. It is possible to have both DMDD and depression. It is not technically possible to have both DMDD and bipolar disorder. The prognoses differ. And that is one of the big points that was upsetting people before the DSM-5, is we're labeling these people with bipolar disorder, we're labeling this 9-year-old with bipolar disorder, this diagnosis is going to carry with them through their entire life. So we really should make sure it's the real deal, because bipolar disorder is a lifelong illness. As it turns out, the majority of people diagnosed with DMDD do not go on to develop bipolar disorder. It was very easy to show there was a problem back in the days of DSM-4, because between 1 and 2% of the adult population has bipolar disorder, and yet about 4.5% of the children in pediatric clinics were being diagnosed with it. And so you really can't have a higher number. There would be attrition. It would need to be a smaller, it would need to be going in the opposite direction, if that makes sense. So the prognosis for DMDD is that you can expect 75 to 80% of those people to not go on to have bipolar disorder. You can expect the majority of them to go on to have major depressive disorder and or anxiety disorders. They more than likely will struggle with significant mental disorders, but it more than likely will not be bipolar disorder or schizophrenia. The last part of the slide here, how does treatment differ? So that's the quickest answer, it doesn't. For all practical purposes, the treatment is very similar when we're right there in the trenches treating it while the person's 9 years old or while they're 12 years old. It may differ in some subtle ways, and we'll talk about that later, but by and large, treatment is often apples to apples. Okay, so this is our independent mountaineer, Bear Grylls, bipolar disorder, better diagnosed myself. And any of you who work in the mental health field know people sure do come in with that diagnosis pre-made. So it is up to us to go back and dig into the symptomatology and find out, is it episodic? Are there discrete manic or hypomanic episodes? So here are some imposters for bipolar disorder. And this is especially important when you consider the primary care doctor, who's actually seeing the majority of people with bipolar disorder. So when there's an upcry that SSRIs and antidepressants are used too much, or an upcry that stimulants are used too much, when you look at the statistics, over 90% of them are being prescribed by primary care providers. The psychiatrists tend to take the heat because in proportion to all the things we prescribe a higher proportion of those things, but we're actually not the people who are seeing most of our pediatric or adult clients with ADHD. It's mostly a busy primary care provider who has a time-limited amount of time and also has a limited amount of specialized education in mental health and treating psychiatric disorders. So some of you may wonder, well, how could these imposters happen if you're maybe a therapist who sees the child for an hour every other week? Well, it's because they're in an office for about 10 minutes once every 3 months with somebody who's not a psychiatrist. Major depressive disorder can fool anybody. That can fool me too. If someone's never had their first manic episode, you can't diagnose bipolar disorder without a manic episode. And if they meet all the criteria for major depressive disorder, they have major depressive disorder. They don't have DMDD, they have major depressive disorder. So that is a justifiable correct diagnosis before the first manic episode. And statistically, the first manic episode is until about 19 years of age. Interestingly, to diagnose bipolar disorder in pediatric populations or adult populations, they actually technically do not ever need to have a major depressive episode. They just need to have a manic episode. Now, 98% of them also have major depressive episodes. I have met a handful of people in my 20-year career that I can say were consistently functionally hypomanic. I called them hyperthymic, and other people in the research referred to it that way. But technically, and really, in the real world, if I see a child who meets all the criteria for bipolar disorder type 1, that's the one that's the real deal with psychotic symptoms, which is loss of touch with reality. And I have ruled out medical causes, which is extremely important. I have ruled out substance abuse. I have ruled out environmental conditions, such as being the victim of abuse or neglect or a non-nurturing environment. If I have ruled these other things out, then a single manic episode, bipolar it is, they almost certainly are going to have a depressive episode within the next 24 months. And the usual pattern, as a lot of you know, is hypomanic or manic episodes when somebody's up above euthymia. Euthymia is kind of our goal mood state for many people. As most of you know, people generally, they don't generally stop at euthymia as they're coming down off a manic episode. It's much more common they immediately crash into a depressive episode. So the typical pattern is quite a bit more clear. ADHD, especially the younger the child is. Now, the younger the child is, the more cautious we should be to make the diagnosis of bipolar disorder. So children who will eventually have bipolar disorder, if they're 6 years old or 5 years old, are most likely going to be diagnosed with ADHD, especially by their primary care doctor. Because who wants to slap a diagnosis of bipolar disorder on a 5-year-old? That's a heavy thing to do and hard to do with confidence. But ADHD, that's 4% of the pediatric population. 2 or 3 kids in every class have it. It's lost much of its stigma. So that diagnosis is given, and sometimes the stimulants help and sometimes they don't. And sometimes other ADHD treatments help and sometimes they don't. Oppositional defiant disorder and conduct disorder go together. Conduct disorder is the more extreme version, but these are what are called disruptive behavior disorders, where the person is willfully doing acts that are antisocial or at least not pro-social and breaking the rules. And so they may be doing a lot of impulsive behaviors like substance abuse or unprotected sex, and those are symptoms of bipolar disorder, only they're not doing it out of impulsivity or abnormal mood states. They're doing it out of a willful disregard for the norms. And then the biggie for imposters, once a person hits 13 years of age, maybe even 12 years of age now, is substance abuse. Got to be ruled out. Very common imposter. So common that I sometimes use a term called drug puller to compare it to bipolar. It can be so similar. Some more sophisticated imposters. So I put my favorite sophisticated people who may have these problems on the screen. Some of you might already know Winnie the Pooh is a cornucopia of psychopathology, and I could probably teach an entire course in psychopathology basing it on an analysis of the different Winnie the Pooh characters. So Winnie the Pooh, or not Winnie the Pooh, what am I doing? Goodness. Here we have Eeyore and Tigger representing the two sides of bipolar disorder. So more sophisticated imposters. If a child has major depressive disorder where they're mostly irritable instead of elated and euphoric, and ADHD. If they have a combination of depression and severe anxiety, if they have a combination of depression and substance abuse, I think you get the idea. Essentially, if they have a combination, or what we call comorbidities, it gets even trickier. And this is actually the majority, or over half of what I see. Is maybe a general psychiatrist saw them. It's still not clear, and it's not clear because there are multiple diagnoses or disorders going on. So how do we differentiate? Well, family history is so important. I can, because I'm doing it right now, emphasize how important family history is. It's one of the few solid tools we have to go by to risk stratify people. And so if I'm seeing someone and neither their mom nor their dad nor either grandma or grandpa has been diagnosed with bipolar disorder, I am very reluctant to diagnose bipolar disorder. It is the norm that at least one parent has bipolar disorder. And if a parent has bipolar disorder, just by virtue of being the genetic offspring of that person, their risk goes up tenfold to have bipolar disorder. If both parents have bipolar disorder, their risk goes up tremendously, 30 to 40-fold. So family history of bipolar disorder, major depressive disorder, and schizophrenia is just so important in trying to separate this out. And then variation in the quality and severity of symptoms, looking at the time, I'm going to move past that because that is really a different way of saying that it's episodic, that the symptoms you're dealing with should be episodic in bipolar disorder, and they usually aren't in DMDD. So moving on, I'm gonna throw out, we're going into kind of the more specific meat of the talk now. I'm gonna just go into what is a mood stabilizer, because that is a term that we hear all the time. It's a term I even use myself, even though I know the problem with it. I use it too, because it conveys useful information to people.
I'm going to jump in real quick with a question before we get into the mood stabilizers. There's a question saying, what can schools put on a 504 or an IEP to help?
Okay, so if it's bipolar disorder, I think it's very important that the IEP reflect the fact that this is a child or an adolescent that is going to be severely impaired at some times and not be functional or able to attend school or probably even to learn for some portions of their life, maybe for a couple weeks here and there. And a child who at other times is going to be able to get passing grades, keep friendships, and even be on an athletics team or an extracurricular activity. So I think that is one very important thing to get across, because by and large, they are otherwise dealing with either two courses of illness. One is permanent illness or injury that's going to be relatively steady in severity and level of dysfunction, or progressively improving problems such as, fracturing pelvis. Terrible, but it's going to predictably get better over time and go away. But this one has this course, and we never know when one wave is coming or how long it will last. So I think a recognition of that as the top overarching concept is crucial, because then that allows the IEP to plan for when they are so depressed that they are non-functional, and when they are so manic that they are non-functional, because there are going to be different problems in those different phases. And it should ideally address reintegration plans, because I hope they never have to leave school, realistically and statistically, they're going to have periods where they're not functional enough if they have bipolar disorder type 1, especially. And so to ahead of time think about reintegration plans that are subject to change based on the situation, I think is also a good idea. I could go on for the rest of the hour about it, but I'm not, because that would maybe be cheating people, but great topic. Okay, so originally when we said mood stabilizer, we were referring to the anti-epileptic drugs, the medicines that prevent seizures, and lithium. Nowadays, when we use the word mood stabilizer, we mean a medication that is good to treat bipolar disorder. So what is a mood stabilizer? It's a medication that's good to treat bipolar disorder. It's a bipolar medication. What is a bipolar medication? It's a mood stabilizer. Yes, it is indeed a circular definition. That is where I have the bit of frustration with it. Now, that said, it does communicate important information. In particular, it communicates, hey, antidepressants, at least by themselves, are not the way to go. We need to go this other way. All right, enough about that. So before we discuss the different classes of drugs, I am going to make you be a little bit more patient and go through some things that are very important to the person that is prescribing the medication, or hopefully are very important to these people. Some medications can have multiple indications. An indication is something that the Food and Drug Administration officially says it's approved for. They can have commercials for it. They can have pharmaceutical representatives market it. They have full approval. And some medications have multiple indications. So, for example, the anti-seizure medication Depakote has indications for migraines, migraine headaches, control of seizures or epilepsy, and control of manic phases of bipolar disorder. Those are all official indications for it. So a lot of times a client will look up the medication and say, why did you put me on an anti-seizure medicine? I don't have seizures. Well, no, you don't. Here's what's happening. So here's a different example. I think Depakote's going to be the next one, so we're going to be able to skip that. Even Prozac, that's a selective serotonin reuptake inhibitor. So this medicine hones in on just one action on one neurotransmitter system. Even something that has that specific of a mechanism of action is officially approved for major depressive disorder, obsessive compulsive disorder, bulimia nervosa, panic disorder, and premenstrual dysphoric disorder that I knew of off the top of my head making this slide. I think that's all of them. There may be others. Interestingly, it nearly got FDA approval to treat premature ejaculation. Why is that? Well, it's because sexual dysfunction is such a common side effect, and one of the specific ways in which it causes sexual dysfunction is prolonged time to orgasm. It's so common that it's virtually predictable, and they were pursuing an indication for that, and then along comes Viagra and shatters their hopes. So we had already talked about Depakote and its multiple uses, and it can be excellent for any of those or not good for any of those. But it certainly can be a great treatment for any of those. Medications in pediatric psychiatry, possibly more than any other specialty in medicine, we use medications off-label. That means the FDA has not given the medication approval to treat that condition. They have given it approval for something to get it to market. And that's really what the pharmaceutical company wants. They want it on the market because they know once it's on the market, the physicians can prescribe it for whatever they want. So getting it on the market is the key. Then the financial incentive for them to get an additional official indication is much less because there's really not much more money for them to make. It's already on the market and people are already using it to treat bulimia. So why spend $6 million in 24 months of doing longitudinal studies at multiple sites to get the indication when people are already using it anyway for that. So FDA approval does not mean everything. It's nice to have, and it's a good reassurance, but it doesn't mean that your doctor has gone off the reservation with what he or she is doing. It would be just important to ask them the rationale. When I started trial psychiatry and in my fellowship, there was virtually nothing on label to treat most pediatric psychiatric disorders. And then one last point, medications by and large have effects. We're the ones that decides what's the desired effect and what is the side effect. And for that, I will refer you back to Prozac, which almost got approved to help with premature ejaculation. By and large, that's a problem, not being able to reach orgasm, or your partner getting frustrated and exhausted because it takes 45 minutes to get there. Adderall, I struggle with some kids getting too thin, their body mass index gets too low. Adderall is used in adults with obesity to help with weight loss. We're the ones that decide what are the effects we want and what are the effects we don't. The medicines don't have brains. They don't really do that. They just have effects. Okay, so when I select a medication, what are some of the specifics that I think about? Well, along with the patient, not even along with the patient, I have the patient identify their top, and I say 2 priority target symptoms because I know they're going to give me 3. If I said 3, they'll give me 4. So I say, what are the 2 symptoms that are bothering you the most right now? The thinking being, I'm going to get them the highest level of relief. I'm going to build that therapeutic relationship strong and fast and that trust. And they're going to be invested in treatment. We're actually helping what they came for, not what I thought they came for. So we identify what's bothering you the most. And maybe it's sleep and aggression. Okay, that's going to lean me a certain way as to where I'm going to go with medications. Then I ask them, is there any side effect that you really, really want to avoid? In adults, I can almost write it down before they say it. It's weight gain. But in children, it's kind of all over the place. And a lot of it has to do with the parent's experience with psychotropic medications, rational or not. If I can avoid it and still treat them well, I'll generally avoid that medicine that the parent has a bias against because that is going to make it less likely to work well and more likely to have side effects due to the parental attitude. So I'll ask them, is there something you really want to avoid? For some people, for some college students who are adolescents, it's fuzzy thinking or memory loss. They have to have that. They're an engineering student, that's their life. And then I want to minimize dangerous side effects. And then I want to minimize common side effects. So in that order. Last of all, I want to aim for the least number of medications needed to effectively treat the condition. What I think is the real travesty is when I see someone on small doses of 4 different medications for bipolar disorder and ADHD, and all of the medications are on too small of a dose to really help the child, but they're on a high enough dose to hurt the child. So they're on a high enough dose to maybe cause problems with high cholesterol or excessive weight gain or excessive daytime sleepiness, but they're not at a high enough dose to actually help the core symptoms of bipolar disorder. So I'm looking, what are the least number of medicines that minimize the common and dangerous side effects that effectively treat the condition? Okay, so specific areas. And this is how everyone, even doctors, talk about them. So we have the anti-epileptic drugs, or AEDs. I only listed, I did not do an exhaustive list. These would be just painful slides to look at. If I did, I picked the most commonly used ones from each class, the ones therapists and parents and are likely to run into the most. So the granddaddy is Tegretol. I put the generic names in parentheses. It is used the least often of anything in this list because it's the oldest and it interacts with quite a lot of other medicines. Depakote was, and officially is, one of the gold standards for treating bipolar disorder. There's a mountain of evidence that it's helpful. We have a mountain of data on its effects because it's used for seizure disorder, which is a common, not common, it's a relatively common disorder that occurs in the pediatric population. So we have all kinds of data on safety and side effects and courses of action. Trileptal is sometimes called Tegretol light. So it works similar to Tegretol, but it got rid of some of the side effects, such as all of the interactions with other drugs. And then Lamictal, which works, all of them work a bit differently. Lamictal is the newest kid on the block of all of these, but one that you are likely to run into if you work in this area. Okay, so pros and cons of the medicine area. So the pro of Depakote has a known effective blood level between 60 and 120 nanograms per deciliter, I believe, of the units. Hopefully I don't have too many chemists in here, to which that's super important. What that means is if I can get a person between those levels, if I can get their level at 80 and keep it there for 4 weeks and they don't get better with Depakote, I know for sure Depakote's not the medicine for them. There aren't many times in psychiatry we can do that we can say this definitely doesn't work for you because we're at the blood level that we know works. Once again, we have our neurology colleagues to thank for that with the treatment of seizure disorders. Lamictal seems to be exceptionally well tolerated by most people, the best tolerated of all of them for most people, and it seems to be more effective for the depressive phase of the illness, which if someone has bipolar disorder type 2 is going to be the vast majority of where they are, way more than hypomanic or manic, and sadly more than euthymic. I already mentioned point number 3, and we've already talked about point number 4, so hoorah for me and us. So some of the cons, Depakote is notorious for weight gain. I tell people up front, you know, it's an average of 20 pounds of weight gain. So if it works wonderful for you, I think it is going to be worth it. But we're going to monitor your weight every visit, which has become very hard with coronavirus and the telemedicine visits, but I'm doing my best. It's teratogenic, meaning it can cause birth defects. So it's advised against for any women of childbearing age, which is a significant portion of my population, and it requires repeated blood tests. And a significant portion of my population and of the world at large has a needle phobia. and will give me all kinds of excuses to never get the blood tests. It's estimated about 10% of the United States population has a needle phobia that's so severe that they will forego needed blood tests recommended by their doctor. Lamictal, it's the rash. If you weren't told about the rash when you were prescribed it, somebody done you wrong, because there is a very small chance it can cause a serious rash that can put people in the hospital, and in rare cases has led to death. So that is very serious. We have learned how to minimize the risks of that to where it's down to 1 in 10,000 people. In general, people have a hard time risk stratifying situations, risk management. In other words, people are scared to go into the ocean because of sharks, but they're actually 200 times more likely to die under the palm tree that they're sitting in under from a coconut falling than they are from dying from being in the water with a shark. So they should actually be running away from the beach to get away from the coconuts. I say that because if Lamictal's prescribed properly, the risk of the rash, of it getting to that serious point where they have to go in the hospital, is so low that it's down in the range of the risk of Tylenol causing liver failure. And so I ask the parents or guardians, are you okay with giving them Tylenol when they have a headache or fever? And if they are, they should be okay with at least considering Lamictal, because it's about the same risk category. The AEDs, one downside is they're unlikely to work as monotherapy. So usually they're going to need to be combined with another agent. Next up, we have the 2nd generation antipsychotics. I just listed the most common ones because of time. I am not going to name them all because they're very hard to pronounce. Risperdal, Invega, Zyprexa, Seroquel, Geodon, Abilify. Risperidone, paliperidone, olanzapine, quetiapine, ziprasidone, and aripiprazole. So now that this is recorded, you can play it at half speed and your doctors with your terrific pronunciation or your colleagues. Pros and cons of this class of medications. A huge pro is a medication from this class has the best chance for monotherapy. So I have the best chance of adequately controlling the symptoms of pediatric bipolar disorder with one medicine. That is huge if we can do that. It tends to have a much more rapid onset of action than the other medicines. Well, that is huge if they're actively psychotic and having command hallucinations to kill their family and burn their house down. So the more emergent and dangerous the situation, the more we think about these. They treat psychosis. So bipolar disorder type 1 is associated with psychosis. This is going to be the only class that's going to directly treat that. And they treat the widest range of symptoms. So they treat psychosis, they decrease aggression from virtually any source, they decrease ADHD symptoms. They just really span a wide range, which really is related to the top one, best chance for monotherapy. I put sleepiness as a pro because that's the point of side effects are what we decide we don't want or what we do want. Very often, anyone in a hypomanic or manic state isn't sleeping. And so getting them to sleep is one of the most important treatments. So that is actually often used as a pro. So cons, sleepiness. Very often they can cause daytime sleepiness or sedation, which can, of course, be problematic in trying to be functional through the day. There are concerns of abnormal movements. There's a certain class of abnormal movements that can happen right away when they first start it that are a concern. And then there is a concern for abnormal movements that can happen over time if the person takes the medicine for years and years. And those need to be discussed with the client and their guardians if they're not young enough to make their own decision before decisions made. Weight gain is fairly common. It's very common in some of them and relatively common in some, and maybe the lowest it goes down to is probably about a 25% chance of weight gain in the best. They can increase blood sugar, which is what leads to diabetes. They can increase cholesterol, which leads to hyperlipidemia, which leads to increased risk of cardiovascular disease, which leads to an increased risk of cardiac disease and dysfunction, which is the leading cause of death in our country. So those are important things. The way to make those safer is by monitoring, but I am going to start motoring because of time. Lithium, look at that. It is in a class all its own. I am not going to talk about mechanism of action so that we can get to some of the more nuts and bolts, but I'm just going to leave it at, it is unique among all the medicines. I will get a patient who has been, people have been trying to control this young person's bipolar disorder for years, and they have been tried on, I am not exaggerating for effect, this is a case I saw recently, a 13-year-old who has been tried on 19 different medications to stabilize him or her, none of them lithium, which is the gold standard treatment for bipolar, but people avoid it because of some of the cons and because it has a reputation, because it's been around for so long. But it can work when nothing else does. It can also not work at all, but it can be the answer when nothing else works. Same thing as Depakote. You can get to a therapeutic blood level, keep it there for 4 weeks, and you can know if it's going to work or not. Reasonable chance for monotherapy, Lamictal and lithium, so the L1s are the two that are thought to be most effective for the depressive phase of the illness. And we have mountains of long-term data available because this has literally been around as long as dirt because it is a basic element on the periodic table. Some of the cons, delayed effectiveness. It takes a while to get to that therapeutic dose, and then it's often 2 weeks at the therapeutic dose before there's a big improvement. Multiple blood draws, again, a problem. A real chance of thyroid dysfunction, not just this theoretical rare thing, something that happens, and a real chance of kidney dysfunction. Narrow therapeutic window, meaning it gets to be quite toxic and potentially lethal at even just double the blood level that's therapeutic. And the person can expect multiple annoying minor side effects, which they're usually willing to put up with if it works wonderful for the bipolar, but it's more the norm with this medicine. Okay, where is the time going? The antidepressants should really not be used first line for pediatric bipolar, but they are, and often that's because the person presents in a major depressive episode. So I've listed them here. This time I'm really not going to pronounce them because I didn't put the generics with them. Some of the pros and cons to antidepressant treatment. Well, they're effective for a wide range of other conditions, comorbid. I listed some of the things Prozac also works with: eating disorders, obsessive compulsive, actually all kinds of anxiety disorders, obsessive compulsive disorder, post-traumatic stress disorder symptoms, although I don't know that it has an official indication for that. And the list goes on of common comorbid conditions. And sometimes even after we get the mood stabilizer working as well as it can work, we just can't pull them all the way out of that depression, this suffering client. And so sometimes we do need to add usually a low dose of an antidepressant, usually with the goal of stopping it when we pull them out of the depression. Cons, well, the big one is they can precipitate mania. So when I see somebody with a strong family history of bipolar, especially, but really everyone, I very much emphasize that within the first couple of days or the first couple of days of going up on the dose, they can just go off the chain. It is fast. It is like an allergic reaction, and it is not subtle. They will be up all night. Their fist will be through the drywall. Almost certainly some physical aggression, sometimes some psychosis, sometimes leads to hospitalization, increases suicidality. Now, I don't really have time to say too much about this, except in the studies, no one actually completed suicide. They give people a false sense of security because primary care docs and all doctors are used to prescribing these type of medications all the time, so they feel like they know them in and out. And patients are used to hearing the names all the time because they have relatives on them. Some side effects, which I've listed, probably the one to note is the transiently increased anxiety. So it's sometimes important, well, it is important to educate the person. You may actually feel a little more nervous for 3 or 4 days, but in the long term, it should help a whole lot with your anxiety. So my thoughts on classifying medications. Well, a drug's class is based on how it first obtained Food and Drug Administration approval. And as I mentioned, once it gets that, there's much less financial incentive to get other ones. So for example, 10X is an antihypertensive, meaning it lowers blood pressure. Turns out it sort of sucks as an antihypertensive, but it's FDA indicated for it. Turns out it's terrific for treating ADHD in comorbid bipolar disorder, and it can be terrific in reducing tics in a condition such as Tourette's disorder. So it is used much more off-label than on-label, justifiably so. We have way better medicines for hypertension. This just brings the point home of when I think of prescribing 10X, you shouldn't need to think this way, but I think, okay, I'm dealing with a centrally acting alpha-2 adrenergic agonist and all of the effects that a medication that has that mechanism of action does. When I prescribe an antipsychotic, quote unquote, I think an atypical antipsychotic, I think, okay, I'm describing something that is an agonist at dopamine receptors and a partial antagonist at 5-HT2A, which is a type of serotonin receptor. And then likewise with the Prozac. Okay, adherence we're going to need to skip, but that graphic should get your attention a little bit. Nobody's going to get better if they don't put the medicine in their mouth and swallow it and get it into their digestive tract. So I'll just let that sit for a couple seconds. Non-pharmacologic interventions are crucial. Sleep is so important, both for pulling them out of the manic episode and for preventing people from going into both manic and depressive episodes. Substance abuse, as the person gets older, the risk gets higher. It is so important to avoid those. Number 1 and number 2 are the cause of the majority of relapses, I would say. Other things that where non-prescribers can be very helpful, reinforcing patient education, maximizing nutrition, making sure they are in a safe and nurturing environment. A mood diary is a terrific tool to really pin down the diagnosis and get the best treatment. So if you're a therapist and you can convince your client to actually do one of those, for me, it is so helpful. It is also so hard to do. I've tried to do them myself with varying levels of success, none of them complete. Reinforce patient education, common side effects, common time it takes to start working. what it will and will not help with. And psychotherapy should, in pediatric bipolar disorder, should virtually always be a big component of treatment. In fact, big enough that I might say the main treatment is psychotherapy and the adjunctive treatment is medications. And I put polypsychotherapy just because they may very well need family therapy as well as individual therapy, possibly even specific therapy to address comorbid PTSD. I think that that is it for my lecture with 0 seconds to spare. I really appreciate you all dealing with my lack of time management. And it was great to be able to speak with you, and hopefully picked up 1 or 2 useful things.
A question that's just come through is, do you have any tips for helping parents or foster parents with accurate or best presentation of symptoms for youth during med management appointments? We already encourage a mood diary.
So yes, so they already do that one. Write down your top 2 things that you want to get addressed at that appointment and mention them within the first 60 seconds of the appointment, because that is how much time a doctor has to take care of something in one appointment. If you give them 5 things, it's like giving the waiter 7 things. You're going to get none of them right. Pick the 2, put the rest for a later appointment. That would be my biggest suggestion.
Excellent. Well, thank you very much, Dr. Jacobs, for your time today and your presentation.
Welcome.
Reminder, a evaluation for today's presentation should be in your inbox. Please fill it out. Also, if you were with DCS, or if you and you need to get DCS credit for it, or if you have multiple people in your office Zooming with you, please let Karen Gray know so we can issue enough certificates to handle for everybody. Again, thank you all so much for coming. Next month, we'll have Khaki Reynolds here for talk on safe baby courts. Thank you all so much, and we'll see you back next month.